Welcome, everyone. I'm excited to kick off today's presentation on comprehensive airway management techniques and safety. Today, we'll explore essential procedures, the equipment involved, and common complications in airway care. Over the next few slides, I'll guide you through the key concepts to enhance your understanding and skills in this critical area. Let's get started. Now, let's turn our attention to Chapter 37, which focuses on airway management. This chapter is all about ensuring safety and effectiveness when it comes to managing a patient's airway. It emphasizes that using the right techniques is crucial for achieving successful outcomes, whether in emergency situations or during planned procedures. The core idea here is that proper airway management is vital for maintaining adequate ventilation and oxygenation. We'll explore essential procedures that help establish and secure artificial airways, covering both emergency and elective settings. By understanding these techniques, we can improve patient safety and improve overall care. Remember, the goal is to keep the airway open, secure, and functional at all times, which is fundamental to our broader theme of safe and effective patient management. Now, let's look at some of the key procedures for establishing an artificial airway. First, we have the tracheotomy, which involves making a surgical incision in the neck to access the trachea directly. This technique is often used when we need long-term airway support or if there's an upper airway obstruction that can't be managed otherwise. It's a crucial procedure for patients requiring extended ventilation. Next, there's nasotracheal intubation. This method is typically reserved for specific situations, like oral surgery or maxillofacial injuries, where inserting a tube through the mouth isn't feasible or practical. It's not the first choice in most cases, but it serves as an important alternative when needed. Finally, the most common emergency approach is orotracheal intubation. This method is preferred because it's usually the quickest and most straightforward way to secure an airway during urgent situations. Its speed and simplicity make it the go-to option when immediate airway management is critical. All these techniques highlight the importance of selecting the right approach based on the patient's specific needs and the clinical context. Let's start with step 1, assembling and checking all the necessary equipment. This is a crucial first step to ensure everything is ready for a safe and effective intubation. First, we have the oropharyngeal airways, which help maintain an open airway during the procedure. They also prevent the tongue from blocking the airway, making it easier to visualize and access the trachea. Next, the colorimetric CO2 detector is used to confirm the proper placement of the endotracheal tube. It changes color in response to exhaled carbon dioxide, giving us immediate confirmation that the tube is in the right place. We also need the manual resuscitation bag and mask. These provide ventilation support both before and during intubation, which is vital for maintaining oxygenation, especially in critical situations. Then, we have the suction apparatus and catheters. These are used to clear the airway of secretions or obstructions, ensuring a clear path for intubation. Of course, oxygen delivery is essential. The oxygen flow meter and tubing ensure a continuous and controlled flow of oxygen to the patient throughout the procedure. By thoroughly checking and assembling this equipment beforehand, we set the stage for a safe, efficient, and successful intubation process. Let's talk about equipment preparation for orotracheal intubation. First, it's crucial to thoroughly check the laryngoscope light source. This means testing the handle, blade, bulb, and batteries to make sure everything is working properly. A fully functional light source is essential to visualize the vocal cords clearly and avoid complications. Next, we need to examine the endotracheal tube, or ET tube, specifically checking the cuff for leaks. Ensuring the cuff is intact means it will maintain an effective seal once inserted, which is vital for proper ventilation and patient safety. Then, we move on to lubrication. Applying a suitable lubricant to the ET tube helps facilitate a smooth and easy insertion. Proper lubrication minimizes resistance and significantly reduces patient discomfort during the procedure. Finally, inserting a stylet into the ET tube is an important step. The stylet provides the necessary shape and rigidity to the tube, helping guide it accurately during intubation. All these steps are key to ensuring the equipment is ready, which ultimately contributes to a safer and more effective airway management process. Now, let's move on to steps 2 and 3 of orotracheal intubation, focusing on positioning the patient and preoxygenation. First, it's crucial to properly position the patient to align the airway structures. We want the mouth, pharynx, and larynx in what's called the sniffing position, which helps us visualize the airway more effectively. Proper alignment makes the intubation process smoother and safer. Next, preoxygenation is a vital step. We do this by using a manual resuscitator with 100% oxygen to fill the patient's lungs with oxygen. This step is essential because it provides a reserve of oxygen, giving us a safety margin during the intubation attempt. It helps ensure that the patient remains well oxygenated throughout the procedure. Remember, if the first attempt to intubate isn't successful, it's important to reoxygenate the patient before trying again. This reoxygenation maintains their oxygen levels and safeguards their safety during the process. Now, let's talk about timing. Each intubation attempt should be limited to around 30 seconds. Keeping attempts short helps prevent hypoxia, which is a drop in oxygen levels that could lead to serious complications. Finally, if we need to reattempt, we prepare for that by making sure the patient is well preoxygenated again. This cycle of positioning, preoxygenation, and cautious timing is key to effective and safe airway management. Now, let's move on to step 4 and 5 of orotracheal intubation. First, hold the laryngoscope firmly in your left hand. This will give you control and stability during the process. With your right hand, gently open the patient's mouth, making sure you have a clear view of the oral cavity. Next, insert the blade along the right side of the mouth, carefully sliding it in to avoid causing trauma. As you advance the blade, displace the tongue toward the left side to create more space and improve visualization. Once the blade reaches the back of the tongue, look for key anatomical landmarks, the arytenoid cartilage and the epiglottis. Recognizing these structures is essential because they guide you to the glottis, which is your target for intubation. Remember, this step is crucial for proper visualization of the glottis, so take your time and be precise. Be cautious not to advance the blade too far. Over-inserting can obscure your view and make the procedure more difficult. Proper technique here sets the foundation for a successful intubation, so focus on control, visualization, and anatomical awareness. Now, let's move on to step 6 of orotracheal intubation, which is displacing the epiglottis. Here, we're focusing on the Macintosh blade. This blade works by indirectly lifting the epiglottis, meaning that the tip of the blade is placed into the vallecula, that space between the tongue and the epiglottis. By positioning the blade there, it leverages the anatomy to help us visualize the vocal cords more easily. This indirect approach is preferred by many practitioners because it often provides a better view without directly touching or lifting the epiglottis itself. It's important, though, to lift the blade gently and avoid rocking on the teeth, as applying excessive force can cause injury. In contrast, the Miller blade is designed for direct lifting of the epiglottis. This means you lift the epiglottis directly rather than indirectly via the vallecula. The advantage here is that it can give a very clear view of the vocal cords, especially in difficult cases where indirect methods might not be sufficient. Again, just like with the Macintosh, careful technique is crucial. Lifting without rocking on the teeth helps prevent trauma. So the key takeaway is that the Macintosh blade relies on anatomical positioning for indirect visualization, making it a popular choice, while the Miller blade provides a direct lift, which can be very useful in challenging situations. Both techniques require gentle handling to ensure safety and effectiveness. Now that we've inserted the tube, the next crucial step is to verify its placement and secure it properly. It's essential to confirm that the tube is correctly positioned in the trachea to ensure effective ventilation and oxygenation for the patient. Once confirmed, we need to secure the tube firmly to prevent any accidental displacement during patient movement or ongoing care. After securing, We should monitor the patient closely to ensure that ventilation is effective and that oxygen levels are adequate. Remember, prompt initiation of ventilation is vital. Don't delay once the tube is in place. Ensuring oxygenation starts immediately can make a significant difference in patient outcomes. Next, we proceed with inflating the cuff immediately to seal the airway. Proper cuff inflation is critical. If it's underinflated, air could leak, compromising ventilation. If overinflated, it could cause damage to the trachea. Always check that the cuff is inflated to the proper pressure. Once the tube is correctly positioned and the cuff inflated, hold the tube steady with your right hand. Use your left hand to carefully remove the laryngoscope and stylet, making sure not to dislodge the tube in the process. When inserting the endotracheal tube, do so from the right side of the mouth with your right hand and avoid following the blade channel to minimize trauma. As you advance the tube, watch carefully to see it pass through the vocal cords. This confirms correct placement. Positioning the tube accurately is essential for effective airway management. Ensuring these steps are followed precisely helps us maintain airway security and optimize patient safety throughout the procedure. Once we have stabilized the tube, the next crucial step is to obtain a chest X-ray to confirm its position. This ensures that the tube is correctly placed within the trachea and not in the esophagus, which is vital for effective ventilation and patient safety. In addition to the X-ray, we use capnography or a colorimetric CO2 detector to verify the presence of exhaled CO2. This is a quick and reliable way to confirm that the tube is in the airway and not mistakenly placed elsewhere. Next, we confirm bilateral breath sounds and observe for equal chest rise. These clinical signs help us verify that both lungs are being ventilated properly, which is essential for effective oxygenation and avoiding complications. Regarding tube depth, for men, the ideal placement is roughly between 21 and 23 centimeters, while for women, it should be around 19 to 21 centimeters. These measurements help us prevent the tube from being too shallow or too deep, both of which can cause issues. Finally, we want to ensure that the tube tip is positioned about 3 to 5 centimeters above the carina. Proper placement here is critical. It allows for effective ventilation and reduces the risk of trauma or other complications. All these steps are integral to ensuring the safety and effectiveness of airway management, tying back to our overall goal of providing comprehensive and safe airway care. Let's talk about the Sellick maneuver, or cricoid pressure, which is a key part of comprehensive airway management. It's important to remember that this technique should only be performed by trained personnel during intubation attempts. Proper training is essential to ensure that it's done safely and effectively, minimizing any potential complications. Now, one of the main reasons we apply cricoid pressure is to prevent regurgitation of gastric contents. By occluding the esophagus, we can reduce the risk of aspiration, which is a critical safety concern during airway management. Additionally, applying cricoid pressure helps us get a better view of the airway. It enhances visualization of the epiglottis, making it easier to see what we're doing and increasing the chances of a successful intubation. Overall, this technique is a valuable tool in ensuring both safety and success during airway management procedures. Let's now discuss nasotracheal intubation, a key component of comprehensive airway management techniques and safety. One important aspect to consider are the potential complications, which include epistaxis, sinusitis, and otitis. These risks must be carefully managed to ensure patient safety and minimize discomfort or further issues. On the flip side, the benefits of this technique include improved mouth care, especially in cases where long-term intubation is necessary. It helps reduce oral infections and makes oral hygiene easier for the patient. When performing nasotracheal intubation, the role of magle forceps is critical. They are used to guide the tube during visualization, helping us place it accurately in the trachea. Proper use of these forceps is essential for a successful procedure. In terms of techniques, nasotracheal intubation can be done blindly or with direct visualization. This can involve standard laryngoscopes or fiber optic equipment. Both methods require skill and precision, emphasizing the importance of proper training. Finally, this approach is indicated when the oral route isn't available, such as in cases of oral surgery or maxillofacial trauma. It provides an effective alternative airway management strategy in these specific clinical situations. Understanding these key points helps us ensure safe and effective airway management tailored to each patient's needs. Let's take a closer look at tracheotomy overview. This technique is a key part of comprehensive airway management, providing a direct airway for breathing when necessary. It's especially useful in cases where the normal airway is obstructed and alternative methods are not effective. The main purpose of a tracheotomy is to ensure the patient can breathe safely and effectively. When deciding whether to perform a tracheotomy, the patient's age, height, weight, and specific airway anatomy all play important roles. Choosing the right tube for the patient is critical. Using the proper size and type helps ensure safety and comfort. Typically, the tracheostomy tube is selected during an elective procedure, which is performed by a physician or surgeon once the airway has been stabilized. This is an important step, as it allows for a controlled environment to create the opening safely. Now, talking about the procedure itself, it involves a surgical approach where an incision is made in the neck to access the trachea. The opening created in the neck is called a tracheostomy, which then allows for placement of the tube directly into the trachea. Understanding this process helps us appreciate how vital it is in managing airway emergencies and ongoing respiratory support. It's a procedure that, when done correctly, can significantly improve a patient's breathing and overall safety. Let's take a closer look at the indications and benefits of a tracheotomy. One of the key advantages is that it eliminates the risk of vocal cord injury, which can be a concern with prolonged endotracheal intubation. It also increases patient comfort significantly, as it tends to be less invasive and more tolerable over time. Additionally, a tracheotomy reduces the need for deep sedation, allowing patients to be more alert and participate in care when appropriate. Another important benefit is that it facilitates secretion removal, making it easier to clear mucus and other secretions from the airway. This also decreases the work of breathing, which can be a real relief for patients struggling with airway resistance. From an indication standpoint, a tracheotomy is the preferred route when there's upper airway obstruction or trauma, or in cases where the airway protective reflexes are poor. It's also considered if an artificial airway is needed beyond about 7 to 14 days of intubation to prevent complications and improve quality of life. Finally, specific medical conditions that require ongoing airway management can also be addressed effectively with a tracheotomy. Overall, understanding these indications and benefits helps us choose the most appropriate airway management technique for each patient, focusing on safety, comfort, and outcomes. Now, let's look at the percutaneous dilational tracheotomy, or PDT. The process begins with inserting a needle and sheath into the trachea, followed by placing a guide wire. Once the guide wire is securely in place, a dilator is passed over it to create the necessary opening. This technique allows for a minimally invasive approach to access the airway. In contrast, the traditional surgical tracheotomy involves making an incision over the second or third tracheal ring. It's a more precise surgical approach, often used when other methods are not suitable. Both techniques aim to establish a safe airway, but they differ in their execution and indications. Understanding these different tracheotomy types is essential for selecting the most appropriate method for each patient, ensuring safety and effectiveness in airway management. Now, let's talk about tracheoesophageal puncture, or TEP, which is a key technique used to help patients regain their ability to speak after a laryngectomy. Essentially, TEP involves creating a small opening between the trachea and the esophagus. This allows air to pass in a way that enables voice production, providing a more natural way to communicate. It's important to understand that after a laryngectomy, patients no longer breathe through their nose or mouth. Instead, All their airflow occurs through the surgically created opening, called a stoma. The creation of this stoma is a critical part of the procedure, as it connects the trachea directly to the outside of the neck, allowing the patient to breathe directly through it. To give you a clearer picture, the stoma is made where the trachea is attached to the skin. This opening is vital for breathing post-surgery and requires careful management to ensure safety and functionality. Overall, a laryngectomy involves the total removal of the larynx, typically because of cancer or severe trauma. While it's a life-saving operation, it also means adjusting to new ways of breathing and speaking. These airway management techniques, like creating a stoma and performing TEP, are essential parts of restoring safety and communication for these patients. Now, let's talk about the obturator, which plays a crucial role during the insertion of the tracheostomy tube. Its main purpose is to guide the tube into the trachea safely and accurately. Once the tube is correctly positioned, the obturator is removed to allow for airflow through the cannula, ensuring the patient can breathe properly. Most tracheostomy tubes are made from materials like polyvinyl chloride or silicone. These materials are chosen because they offer flexibility and comfort, which are essential for patient safety and ease of use. For long-term cases, metal tubes are also an option, providing added durability and stability. Moving on to the cuff and pilot balloon, these components are vital for securing the tube in place and preventing air leaks. They are especially important in patients who need mechanical ventilation, as they help maintain a proper seal and ensure effective ventilation. Next, the flange or faceplate acts as the external anchor for the tube, keeping it securely positioned on the neck. The outer and inner cannulas are also key parts. They help keep the airway open and make cleaning easier, which is essential for preventing infections and maintaining patency. Finally, the typical tracheostomy tube is composed of several parts: the flange or faceplate, outer cannula, and inner cannula. Some tubes might only have one cannula, along with a cuff, pilot balloon, and an obturator for insertion. All these components work together to ensure the tube functions properly and the patient's airway remains secure and manageable. Now let's take a closer look at the fenestrated tracheostomy tube. This device is designed to support both upper airway function and ventilator use, making it quite versatile. Its design offers flexibility in patient care and respiratory management, which is crucial in many clinical situations. One of the key features is its dual functionality. For example, if a patient needs to be returned to ventilator support, we can simply reinflate the cuff, reinsert the inner cannula, and remove the cap. This process allows for a seamless transition back to ventilator support without too much disruption. Additionally, the fenestrated tube allows us to assess upper airway function effectively. By capping the proximal opening or placing a speaking valve while keeping the cuff deflated, we can evaluate how well the patient can use their upper airway. This assessment is important for determining readiness for weaning or speech. A distinctive feature is the opening in the posterior wall of the outer cannula above the cuff. When we remove the inner cannula, this fenestration opens, allowing air to pass into the upper airway. This opening mechanism is what makes the device adaptable for multiple functions, whether for ventilation, speech, or airway assessment. Overall, the fenestrated tracheostomy tube provides a practical solution that balances airway management with patient safety and comfort. Now, let's discuss needle-based airway access for emergency oxygenation. This technique is primarily used as a temporary measure to sustain oxygen levels when more definitive airway management isn't immediately possible. It's a quick and effective way to buy some time in critical situations. Moving on, percutaneous transtracheal ventilation involves creating a surgical airway through the cricothyroid membrane. This method provides a direct airway access point in emergencies, which can be life-saving when other methods fail. The cricothyroidotomy procedure is particularly important in critical scenarios. It's typically used in cannot intubate, cannot ventilate situations, those dire circumstances where the patient's airway is compromised and immediate action is essential. These situations are life-threatening, and recognizing when to perform this procedure can make all the difference in saving a patient's life. Connecting these techniques to the overall theme of comprehensive airway management, they highlight the importance of being prepared with multiple options to ensure patient safety in emergency situations. Let's take a closer look at the risks associated with prolonged pressure from artificial airways. When a tracheal tube or other airway device is in place for an extended period, it can exert continuous pressure on the soft tissues of the airway. This constant pressure can compromise blood flow, leading to tissue ischemia, which is essentially a lack of oxygen to the tissues. Over time, this can cause tissue necrosis, meaning the tissue begins to die, and can result in serious complications like ulceration or airway damage. This highlights the importance of vigilant monitoring and proper management of airway devices. We need to ensure that the pressure exerted by these devices is minimized, and that the airway is checked regularly for signs of tissue injury. Recognizing these risks early is key to preventing complications and ensuring patient safety throughout airway management. Remember, maintaining a balance between securing the airway and avoiding tissue damage is a critical part of comprehensive airway care. Let's talk about laryngeal and tracheal lesions, which are important considerations in airway management. Close observation after extubation is critical because airway swelling can develop rapidly, and catching it early can make a big difference. Timely intervention can help prevent life-threatening complications, so monitoring is key. Once the patient is extubated, post-extubation monitoring becomes essential. Granulomas and stenosis are potential tracheal complications that can develop over time, and severe issues like tracheoesophageal or tracheonominate artery fistulas, although less common, are serious concerns we need to watch out for. In terms of tracheal complications, patients often present with symptoms like hoarseness and stridor. These are signs that the airway may be obstructed or inflamed. Within the first 24 hours after extubation, close monitoring for worsening swelling is crucial because early detection can facilitate prompt management. Moving on to airway symptoms, vocal cord polyps or granulomas can develop as a response to trauma or irritation from intubation. These conditions might need medical or surgical intervention if they cause significant airway obstruction or voice changes. Vocal cord complications are also common. We often see glottic edema and inflammation of the vocal cords, which can impair voice and breathing. Additionally, ulcerations of the larynx and vocal cords may occur, further complicating the clinical picture. Finally, understanding the range of common laryngeal injuries helps us anticipate and manage potential issues. These injuries include edema, inflammation, ulcerations, and even granulomas. Recognizing these early signs and symptoms allows us to intervene appropriately, ensuring patient safety and optimal airway function. Let's talk about preventing airway trauma, specifically focusing on tube movement and sedation. Choosing the correct airway size is absolutely crucial because an ill-fitting tube can cause injury. It's important to avoid unnecessary changes to the endotracheal tube once it's in place, as these can increase the risk of trauma. When it comes to airway size, nasotracheal tubes often have an advantage. They're generally easier to stabilize. This added stability helps minimize the chances of tube displacement, which is key to preventing injury. Now, sedation plays a significant role here as well. Proper sedation helps prevent patients from self-extubating, which can lead to trauma. Ensuring the right level of sedation is vital for patient safety and to reduce complications. Finally, let's remember that tube movement is a primary cause of airway injury. Movement can lead to ischemia and ulceration of the soft tissues, which are serious issues. Stabilizing the tube effectively is essential to reduce these risks and protect the patient's airway. Now, let's discuss prevention of airway trauma through cuff pressure management. Proper cuff inflation is crucial because it significantly reduces the risk of ischemia or tissue damage caused by insufficient blood flow. When the cuff is correctly inflated, it also ensures effective airway protection, helping to prevent complications during patient care. Moving on, it's important to understand that excessive cuff pressure can actually damage the tracheal mucosa, which is the delicate lining of the windpipe. That's why staying within the recommended pressure range is so vital. It minimizes the chance of injury. Additionally, maintaining proper cuff pressure helps prevent aspiration of oral and pharyngeal secretions. This is a key component of airway safety, as it reduces the risk of pulmonary infections and other complications. So, what is the optimal cuff pressure range? Maintaining pressures between 20 to 30 centimeters of water, cm(H2O), is considered ideal. This range strikes a balance, ensuring the cuff is tight enough to protect the airway but not so tight that it causes tissue damage. In summary, managing cuff pressure properly is a vital part of comprehensive airway management, helping us keep patients safe from trauma and aspiration while ensuring effective ventilation. Let's take a closer look at the impact of different cuff types on the trachea. Here, we see the comparison between low residual volume, high-pressure cuffs and high residual volume, low-pressure cuffs. First, with low residual volume, high-pressure cuffs, the pressure is concentrated in a small area. This can significantly increase the risk of damaging the tracheal wall because the pressure is not evenly distributed. Prolonged use of these cuffs can even cause necrosis of the tracheal mucosa, and post-mortem examinations often reveal black necrotic areas, which are signs of tissue death due to sustained pressure. On the other hand, high residual volume, low-pressure cuffs are designed to distribute pressure more evenly along the trachea. This minimizes mucosal injury and reduces the risk of damage. That's why choosing this type of cuff is so important, especially for patients who require long-term airway management. It helps preserve the health of the trachea and prevents serious complications. In summary, understanding these differences is key to ensuring safe and effective airway management, aligning with our overall goal of patient safety.